At first, I would like to thank the BICC organizer for this big opportunity. This is a very big opportunity for me, I must say, to represent my small work. My today's topic is Fast Forward Trial, Practice Feasibility in Bangladesh. To know about the Fast Forward Trial, I have to look back on 2008, where the first time the START-A trial was published and showed that 41.6 gray in 13 fraction is a similar control like 50 gray in 25 fraction, which is a conventional regimen we used to follow before the START-A trial. Then START-B said the similar, they showed the similar control like START-A trial, where moderate hypofractionation was used, 40 gray in 15 fraction. Then in first trial, for the first time, 1 week schedule was introduced, 28.5 gray or 30 gray once weekly regimen has similar control like 50 gray in 25 fraction regimen. And finally, in Fast Forward trial was published on 2020, where 26 gray in 5 fraction over 1 week is non-inferior to the standard of 40 gray in 15 fraction over 3 weeks. Now, come to my background of my study. Is the Bangladesh is the most common cancer is the breast cancer in female. The current radiation practice in our country is 40 gray in 15 fraction over 3 weeks, which is coming from the START-A and START-B trial I have mentioned. Considering our radiation patient burden in limited resource, implementation of Fast Forward trial I thought could be a great option for our early age breast cancer patients. So currently we are practicing 40 gray in 15 fraction over 3 weeks, and Fast Forward trial we have implemented like Fast Forward trials 26 gray in 5 fraction over 1 week in adjuvant setting early age breast cancer patient. Rationale of this study was Asania Mission is a high burden radiation center in our country. We have 2 LINAC machine and 1 Cobalt machine, and we are treating over 2,000 patients in a year. So I thought the Fast Forward trial could be a great option for early age breast cancer patient to save our machine occupancy period and to help our poor patient, to give them a financial benefit. The material and method, it is a prospective study where this study was done in Radiation Oncology Department of Asania Mission Cancer and General Hospital. The sampling method was convenient and purposive sampling. Eligible patients were received the adjuvant radiation to the whole breast or chest wall. Patient with whole breast had received boost to the tumor bed. Total dose was 26 gray, 5.2 gray per fraction in 1 week. Inclusion criteria. All the patients had histopathology proved invasive breast cancer was included in the study more than 18 years. The patient underwent breast conservation surgery or mastectomy. The ECOG performance status was up to 2, and stage was pathological T1 to T3 and N0 to 1. And the simulation was done in supine position with breast board, and face was to the contralateral breast side, and CT laser alignment was done, and fiducial was placed appropriately. And during the whole breast scenario, the breast was marked into the superior, inferior, medial and lateral border by clinical palpation, and 5 mm slice thickness was taken. The contouring or treatment planning, we followed the RTOG breast guideline, where the 3-dimensional plan was done by the 3D CRT technique, and 2 medial and lateral tangent field was introduced for doing the plan, and ipsilateral lung, heart were shielded by multi-leaf collimator if possible without compromise the PTV coverage. 6 MV beam energy was used. The boost phase was planned by photon beam. This is a picture from our TPS where the we can see the contoured chest wall volume right sided. It is a planned picture taken from our TPS. So, result and discussion. In this study, we have delivered 8 post-mastectomy patient and 2 breast conservation patient as per fast forward protocol. They took 26 gray over 1 week in 5 fraction. As we don't have the deep inspirational breath hold technique, we only took the right sided patient. The whole breast was irradiated 26 gray in 10 fraction. 10 gray boost was given to the tumor bed, and patient was assessed at the first day of radiation, at the 5th day, and 1 month after treatment completion. And our toxicity was assessed by RTOG skin toxicity criteria. Skin toxicity was seen, and there was weekly assessment was done after the end of the radiotherapy and 1 month after radiotherapy. In this study, the most difficult thing for us to gain the lung dose, ipsilateral lung dose, which is needed to be less than 17% in 30% volume of lung, which couldn't be achieved at the most of the cases. Other parameters were achieved. The more than 90% of the volume get 95% of the dose. On evaluation of the skin toxicity, patient didn't had any skin, only the grade 1 toxicity after completion of the RT, but after 1.5 months during the RT in assessment, some few patients said they had grade 2 toxicity on 2nd or 3rd week of their treatment. Here the first picture, it is one of my patient had grade 2 toxicity at the 3rd week after radiotherapy, and another patient, this is a patient after 5 days of completion of RT, there is grade 1 toxicity. This is a RTOG skin toxicity criteria. So, from my study, I can say the ultra hypofractionated regimen is cost effective, has lesser duration, our low machine burden, and it's comfortable for patient. And I have limitation of this study, but I could find a very few patient till now, and late toxicity I couldn't document till, and left sided breast couldn't be included due to I have mentioned that we don't have DIBH technique. In conclusion, fast forward protocol could be standard protocol for patient in a post-operative invasive early age breast cancer. Moreover, in country like us currently dealing with huge burden of radiation patient, this protocol can save more machine occupancy time. Thank you. I am truly grateful for the whole radiation oncology department of Asania mission, especially my physicists who worked very hard for my journey. Thank you everyone.